I thought it would be rather nice to continue the theme of sweat gland tumors for beginners. And I've got two cases to show you in this presentation, which Antonina Kalmykova of CSD Health Care Kyiv shared with me. And they're both lovely examples of one of the more commonly encountered tumors, which is the mixed tumor of the skin, or the sometimes called chondroid syringoma, largely because some of them do show well-developed cartilaginous differentiation, although these two examples, that's not very well represented. Now, people have for quite a long time have argued about the question of whether these tumors are of apocrine or ecrine origin or derivation. And I was a great admirer of John Headington way back in the days when I was working at St. John's Hospital, and he described the ecrine variant of mixed tumor, and as a sign of respect to him, I was constantly trying to diagnose this variant. But to be honest with you, I don't see any real merit in it. I think mixed tumor is a tumor which may show most commonly shows apocrine differentiation. It sometimes shows follicular differentiation, and I suppose it may show ecrine differentiation, but none of that really matters. What matters, I suppose, is recognition of a tumor as being a mixed tumor and making sure that there's no evidence of any carcinoma anywhere. Now, these are fairly commonly encountered tumors, and most of them occur on the head and neck region, although you may get them elsewhere, obviously, and they present as variably sized firm nodules in the dermis or subcutaneous fat. And this is a nice example here in which we can see there's I suppose you'd call it a pseudocapsule of compressed connective tissue, mostly around the outside, but it's not so obvious on this right-hand corner. And it's composed of epithelial elements. There is obviously foci of fat, and then there's a stromal component. So those are the three main elements in a mixed tumor. So let's have a look at this in a bit more detail. Well, much of the tumor is composed of epithelium, in which we can see evidence of both ductal differentiation and glandular or so-called tubulo-alveolar differentiation, and we'll look at this in a bit higher magnification. And there you see typical foci of ductal differentiation, in which there is a well-formed hyaline, almost refractile cuticle. So those are the small ducts. Sometimes these represent intracytoplasmic lumina, which I think is probably what we're seeing here with these smaller ones. So ductal differentiation, and then I just wanted to, there's a bit of stromal component. I suppose it's mixoid. You could maybe wonder whether it's going towards chondroid. I'm not really convinced. And here we have tubulo-alveolar differentiation. So this is the secretory component of the gland. And in this example, I think we're seeing apocrine differentiation with very abundant cytoplasm protruding into the lumen of the gland as a bulbous process. I don't think well, you might wonder whether there's a hint of decapitation secretion, but I wouldn't say it was very well developed. And there is more glandular differentiation there. So ducts and glands and stroma. Now the stroma contains lots of spindle cells and is typically very mucinous, as you see in this example. Now I just want to go down. I made a couple of some annotations and I've forgotten what these were for. So we'd better have a look at them. Oh yes, this was a field where I think we're sort of pretty close to chondroid differentiation there, and that's about as good as it gets in this example. Sometimes chondroid differentiation is very marked, and you can see calcification in mixed tumor, and sometimes you can see bone formation. Now the stromal cells are variably spindled, or they're plasmacytoid, as you see in this field here, where they have abundant eosinophilic cytoplasm and the nucleus is shoved towards the periphery. And in some cases, the stromal cells can are vacuolated, so you can have clear cells. Now let's see what else we can pick up on this example. We'll go back. This is the second piece here, and let's have a look. It's much the same. Oh, this I think I noted because it just shows rather nice plasmacytoid stromal cells, as you see there. And it's the stromal cells that are responsible for producing the chondroid, if that's a feature. And here's another one. I marked this one. Oh yes, sometimes you may see clear cell change in the epithelial component, and this may well be due to glycogen. Sometimes you may see sebaceous differentiation, but I'm not desperately convinced about that. Hair follicle differentiation can sometimes be a prominent feature in mixed tumor, and you can get any element of the hair follicle represented. Interestingly, that looks like an erector pili muscle. I don't know whether it is, but it sort of looks like one, as if to suggest that we do have some follicular differentiation. This sort of structure here looks a bit like a trichoepithelioma, but we're not seeing any stromal cells related to that epithelium. But I suspect that's probably what that is, and that muscle would add some support to that. Now, was there anything else that I wanted to show you on this one? I don't think so. Just to me, mixed tumors and H&E diagnosis, I don't see any need for doing any immunohistochemistry. But if you have a mind to, you can always look at the duct and glandular differentiation with EMA or CEA or high molecular weight keratin, and the myoepithelial cells you can highlight with S100 or smooth muscle action or calponin. Now I just wanted, what I remember, to touch on atypical hydrogenome. I think this is a very vague entity, and I'm not sure I believe in it really. The point is, sometimes the stromal cells in hydrogenome can become pleomorphic with hyperchromatic nuclei, and their they're sometimes multinucleated, and they can catch your eye and worry you somewhat, but I don't think they really mean anything very much. You don't tend to see mitotic activity in a hydranoma. Well, I mean, you probably will find the odd one, but it's not going to be a conspicuous feature. And just when we're on the talking about atypical, we also need to think of hydradenocarcinoma arising in a mixed tumor, so-called malignant chondroid syringoma, and that's a dreadfully rare tumor, and it's a high-grade tumor with significant metastatic potential and mortality. But the only occasions that I've ever diagnosed a malignant chondroid syringoma have either been in a patient in which there is pre-existent chondroid syringoma associated with a carcinomatous element, or a recurrent tumor in which the original biopsy was clearly chondroid syringoma, but the recurrence is malignant. And it's worth noting that sometimes malignant syringoma can have a carcinosarcomatous, or if you like, a metaplastic component with malignant chondroid and even malignant osteoid. So that's that case. And then we have another one which is equally beautiful and is slightly different. No, it's here we are here. So I've obviously gone to town with annotations on this one. And again, it's circumscribed. It's got a false, there's a very nice pseudocapsule around it, sort of densely hyalinized. And this one has got very marked cystic change. Some of the cysts contain keratin, and I think in this one, it almost looks like multiple epidermoid cysts, which in places have ruptured, giving rise to a histiocytic and we'll wait for the picture to settle down, with a histiocytic and giant cell reaction. And so that's a little feature that is a bonus. And also this one shows very marked calcification. And then I've got a couple, yes, this bit's nice, because here this is glandular differentiation, so, and it's apocrine, because there are very well formed apocrine snouts, which are really very nice. So that's in this example. Now Antonina, I think, has been annotating this as well, but I don't know why I don't know what this refers to, so I'm afraid I can't comment on that. There is an additional feature which is really nice in this case. We'll go to a lower power. Yes, let's look at this one. This is quite special. So in this field, it's very similar to the previous one. There's lovely apocrine differentiation there. So this is glandular formation with cystic change, as opposed to the ductular elements that you see in the middle. So you can contrast glandular, sometimes called tubulo-alveolar. I'm not quite sure why it's called that, but that's what people say sometimes. And this one was quite nice, because I think here we're seeing some vacuolation of the myoepithelial cells. And if just to remind you, myoepithelial cells can be spindled. they can be clear cell, or they may have abundant eosinophilic cytoplasm, looking almost plasmacytoid. And it's these stromal cells that are responsible for cartilaginous differentiation, which wasn't present in this tumor. But there's something that's really nice right at the edge here, which just shows that you can get follicular differentiation. I'm hoping that all of you will recognize this as a focus of ghost cells, very, very beautiful, which is something that you see in pilomatrixoma, which is a hair matrix tumor. So that confirms in this particular example that we do have evidence of follicular differentiation. When you get hair follicles in our hair follicle differentiation in a mixed tumor, it can be anything from as we've seen from the matrix all the way through to frank hair shaft formation and everything in between. And I think that's all I have to show you. It's a shame I don't have one with abundant cartilage, but I suppose you can't have everything. Anyway, I hope these two cases will be of help to those of you who are just embarking on your dermatopathology careers. And thank you very much for listening to it.